Okay, good afternoon. Right, so I hope you can hear me and the people at home also you could hear me. If you cannot hear me, please write a comment on the YouTube so I could adjust. Uh, there is one, I think one of us or two of us who isn't well, so uh, our student is at home watching this. Hopefully the learning is not diminished as much as if we don't have this live stream. Okay, we are now in week number 10 of the course. I understand that this is usually the time when people are very busy and are very overwhelmed with various term papers and tests, and I'm not sure if you have projects in other subjects. Um, so I think I could say this. Well, no prizes for guessing it. For reflective journal, well, if you want to submit early, right? I said that earlier for number two, I'll say the same. Then you could focus on your project. In fact, I think I have received one or two early submissions already from this class. Yeah, I haven't marked them yet, but I saw the submission, which is great. So you could manage yourself accordingly. Of course, you have the time from now, anywhere from now until the due date, in fact, due time, to make changes to your submission, right? And then your final submission is that will be marked and graded, not your earlier, if you have more than one submission. Um, Perhaps I could say something else about the project. Um, um, if you wish, I kind of, from the discussion I had with each of the groups online, right, during the breakout groups, kind of had this idea, at least at that point, which is 2 weeks ago, that some of us are, out of, I think, your good heart, you want to, well, short of saying save the world, you want to, do what you can to advocate and make a difference. So, um, and I really like it. I really appreciate and respect that. Just that it initially some of the groups tend to have a larger than manageable scope. That's what I want to say, which hopefully I have helped to kind of curtail and try to help you understand how you could curtail the scope so you could give enough substance and depth to the project. Actually, if you think about it, advocating for any causes, social causes, political causes, climate change, you find that uh, the more successful ones tend to start with one or two quite targeted issues with targeted audience, if you like. And then they kind of branch out from there. They kind of expand their work from there. They kind of get others involved when others see the success or see the fruitfulness, the meaning of their message, of the advocacy message. So if you consider this as kind of a seed, as like a beginning of making some change, then I hope you will not feel so burdened that you're not addressing A, B, and C, and D, and E, and you're just addressing A, and that's fine. For the purpose of grading you, yes, that's fine too, of course. Right? What I hope to get out, hope you will learn out of the doing of the project and the final output is two things. One, really the thinking process of advocating a message. So scoping the problem, identifying who is the target audience who should hear about the problem and hear about your solution, and then explicating in writing and also in verbal communication, right? The way to get this done from the problem identification to the sort of the message being spread, being communicated, the processes, various micro decisions made, various sources you consulted and stakeholders, various discussions, debate, perhaps even argument within your group of four or your group of five, right? It's part and parcel of the learning process, of the advocacy process. There will not be any advocacy group I know of that really didn't have any internal debate amongst them. You know, yes, of course they have a common message. Of course they would have a common, you can say, mission or end goal or a few issues. But yes, there would be various ways to get there. There'll be various approaches to to identify the problem, to, who they should talk to first or target first, and so on, right? So I hope that alleviate some burden you might feel. I just want to begin by asking, is there any clarification or questions on the project so far? Is everybody okay? Is there anyone who is feeling very burdened and you really think you can't cope, or your group is lost, or I don't know, or you want to do A, in the end you end up not even doing B, your plan B, you had to go to some plan C or D, and that is very devastating or very, I don't know, unpleasant. Is there anyone who needs anything, any clarification so far? I mean, of course, you can come to me individually, but if I can have, yeah, I can spend some time on that if you need to. Anybody, any group. Anybody doesn't know what you would need to write about, because the written piece is an individual work. Okay, everyone is fine, huh? Okay, that's surprising. Okay, we'll see. Okay, we'll see as we go along. We'll see. Sometimes, yeah, some of these things come as you discover them. And then when you discover them, you realize, okay, oh no, I only have how many days to my deadline. Oh no, I better email Prof quickly, or I better ask him or her quickly. And then, oh no, he hasn't replied for 1 day. How am I going to do? I'm going to be stuck, right? Okay. So hopefully you don't catch yourself in this kind of situation. Well, I think I have when I was an undergraduate. I have. Right? Thankfully, it wasn't for a psychology course. It was for something else. Yeah. So so that much I can share with you. Personal experience. Any no last questions? No. Okay, fine. So let's get into today's topic now. This is a topic that late life mood disorders is really a topic that affects, I think, seniors, or you can say older people, as much as their caregivers, even as much as their family members, i.e. you and I. Okay, it is you can say a topic which part of it is an issue, part of it is knowledge, right? That anyone who is interested in gerontology or geropsychology will probably almost encounter quite quickly, or kind of the first one, either because there is personal experience of that person, or because he or she is put in a position to have to kind of fix some kind of related issue or problem, this area of a person or of a group. So this is one of those in geropsychology, a topic that we consider complex. There is biological basis to depression, as you know. Then there is cognitive. Then there is affective, right? Then there's behavioral. There are actually a few others, right? Those of you who have taken the course on abnormal psychology and then psychopathology would have heard about the various theories, which I will not cover, right? Partially because two reasons. One is that many of these theories are what we call grand theories, or big theories for depression, for mood disorders. Many of them, I would say even most of them, haven't been subjected to investigation with people 65 and above. So that's one reason. Second is, we find that mood disorders is somewhat different among older people. You would see in the course. If you have read the textbook chapter, I think it's chapter 20, you would find that, well, at least the conclusion bit, if you haven't read anything else, if you just read that 2 or 3 paragraphs, you would have read that the authors say that one of the main reasons is that depression or mood disorder often happen in tandem with other disorders in older adults. It's not to say that younger people are easier to treat, but we are saying older adults is much harder when it comes to mood disorders. Of course, you know there are various types of mood disorders in DSM-5, right? So there's major depression, MDD, then there is dysthymia, there is seasonal affective disorder, then there's bipolar 1 and bipolar 2. Yes? Right? You know those. Now, in already those each of those disorders entail different kind of slightly different treatments, and are not easy for clinicians to manage, though we have solutions, psychosocial, psychological interventions that worked effectively. In older adults, among older adults, you'll find that often any of these disorders that I've mentioned also come together with one or more physical condition. So stroke, some form of cancer, say a hip fracture, right? And many of these times, this physical condition is or are also chronic. So you know that already mood disorders and many of those psychopathologies are not like, you take the medication and you recover, right? Are not like, so those are already chronic to a certain extent, like takes time. And multifaceted treatment has to be directed at various facets. Now, these older adults have all those facets that need to be taken care of just for mood disorder, but they also have many other facets that need to be taken care of when it comes to the physical condition, right? That's true. So you can imagine the complexity, right, of these, you can say, late life mood disorders. So I will not be touching on anxiety disorders specifically, though I'll make some mention for two reasons. One is that many of the etiology and treatment are similar. Second is, in late life. And secondly that um, is, is that a lot more research has been done in this area, mood, more than anxiety. So I will be focusing more on late life depression, late life mood disorders. So that's today. Okay, so that's my introduction. And we'll look at the textbook will give you the epidemiology, i.e. prevalence and incidence rates in the US. So I don't want to repeat that, you can read. I will show you the epidemiology in Singapore based on a study conducted and published in 2016, conducted before that, of course. I will also, in that study, bring out the risk factors found in Singapore of late life mood disorders. So they're kind of, I would say, maybe about 70, 80% similar to, right, the risk factors you read in the textbook for the US population, late life, right? So the way we cluster these risk factors are the same: social, demographic, biological, and then psychosocial. In particular, I would highlight this hypothesis called the vascular depression dementia hypothesis. Yeah, it's quite a mouthful, 3 words, with the word hypothesis at the back. Right, and then after the debate, depending on what are the topics and points raised, I may or may not address some of those, you could say, risk factors related to suicidal behaviors of older people, which actually are, if you have read the textbook once again, quite similar. I'll say once again, about 70% similar to the risk factors you can see in late life depression. By the way, you remember that suicide is one symptom of depression, right? And then finally, we'll talk about management and treatment. Okay, I'm mindful at this point that some of us, when we start to entertain the thought of suicide and suicidal behavior, that you might feel uncomfortable. Okay, from time to time, from point to point, you may not feel anything now, you may feel later, or you may feel something now, but after that, your discomfort may abate. Whichever the case is, I want to allow you to take a break, leave the room if you need to, right? So, and of course, if after the whole class you feel distressed, after the debate you feel distressed, come talk to me. I'm happy to listen to you. All right. Okay. I wonder if I should do the normal introduction or should I do the, let's see, because I know you can read. uh, okay, maybe let me have a show of hands. From among the psychology courses you have taken so far, how many of you have actually taken abnormal psychology already? Hands up. Just roughly. Wow, 2/3. Oh, almost everybody. Okay. In fact, everybody. Okay, thank you. How many of you have taken beyond abnormal psychology, the next one? The next one is what? Clinical psychology. That's right. Hands up. Anybody? Okay, about a third. That side, anybody? 2 of you. Okay. Thank you. Thank you. Thank you very much. Okay. And how about there's another child psychopathology? Anybody? Child psychopathology. There's a course on that. I think Pei teaches that. Yeah. Is it right? Thank you. Thank you very much. Okay, another about a third of us. How many of you have taken all the courses in clinical psychology related, all the trauma and all those, or waiting to take those level 4,000 modules on those clinical aspects? Okay, one of you. One brave soul, one honest and brave soul. Thank you very much. Admire your bravery, courage. Okay, all right. Okay, so that means words like incidence and prevalence is not new to you, to most of us, right? I don't even have to touch on what is DSM-5 criteria. You know where to find that and what that is. I don't have to go into detail on each of the various types of mood disorders. You know what those are? Excellent. Okay, let's see what else I don't have to go through. I've mentioned this thing already, the second last point, that comorbidity, right, is often involved. And you have heard of this term, comorbidity, yes? Just to be clear, the word morbid, right, refers to illness or disease. So co means co-occurring, okay? So that is different from mortality, which refers to death, right? So there's no such thing as co-mortality, because when you die, you die. When I die, I die. Yeah, right? Okay, probably the last point here. Longevity and increasing age-related incidences of mood disorders actually both are found to increase the prevalence of older people or older persons with these mood disorders. That means what we're saying is, look, people are getting older. When they get older, they move into late life. So they have various possible conditions. One of them possibly is a mood disorder. Second, there are also other physical conditions that have higher incidences or higher likelihood due to age, just simply due to age, right? Like dementia, like Alzheimer's disease. So if you put those two clusters of factors together, we would be able to say, arguably, or debatable, of course, that older people with mood disorders, or what we call late life depression, is fast becoming, even in Singapore, a public health concern. Right? Okay, I think that's as much as I want to say. Any questions on this one? Quite straight. Oh yes, those 2 points in yellow. So subsyndromal depression refers to depression that doesn't meet the criteria of diagnosis on DSM-5, but nevertheless exhibits symptoms that's distressful enough or distressing enough to the individual that warrants concern, either by a clinician or by somebody who is a professional. So that's what we call subsyndromal depression. So sometimes when we say this is a case of depression, then for the subsyndromal one, we'll say this is a sub-case of depression. That's just a commonly used term in the clinical setting. So we actually refer to people who still have this experience called depression, but fortunately for them, they are not so severe and haven't reached the diagnosis, can say, threshold yet. But that doesn't mean that clinicians, doctors, and nurses and whoever should not take care of them. Okay. Anxiety disorders. Okay, so that you already know. I stated a prevalence there I stated a prevalence there. So that is different from mood, just to be clear. Okay, I think this is quite clear. What else do we have? Okay, so this is the study. This is the study that you can easily find it on NTU Library. First author is Subramaniam. This is the title: Results from the Well-Being of the Singapore Elderly Study. Right. So this particular study essentially gives us the prevalence and the incidence rate. I don't expect you to be able to read this because I will actually go through this in the subsequent slides. Right. It also gives us several of those risk factors. So this is, I believe, a good study. You can say it's quite a landmark study when it comes to Singapore late life depression. All right. People at home, I hope you're okay. All right. Questions? Nope. Okay. So in this study, the investigators used primarily this tool called the GMS-HCAT, Geriatric Mental State Automated Geriatric Examination for Computer-Assisted Taxonomy. well, it's a mouthful. Essentially, it is a tool, it's an inventory, right, to measure the level of depressive symptoms using the computer, of course. So there is a taxonomy, there's some kind of structure, and then participants go in to answer various items, right? So although they carried out the survey in, I think, 2013 or 14, well, later on we can read, right? However, the data that has been collected in this survey, in this study, was weighted to the 2011 Singapore resident population. That means citizens and PRs in Singapore. Why weighting is done, right? You will hear repeatedly in other kind of research methods courses that weighting is often done to give representativeness. Okay, so these are not 65 but 60 and above residents. Prevalence rate in Singapore at that point, 3.7% depression diagnosed, and 13.4 undiagnosed or yet to be diagnosed. All right. Okay. You probably have this slide with a white background and the black words, right? I have a black background and a white word because I realized the screen would not capture the white background too well, it would be glaring. So I hope you could read either from your own screen or from here, right? Those parts in red, 59.8% of all the cases, not of all the participants, it's all the diagnosable people, right, belong to this age group, 60 to 74. So the beauty of this study is we have beyond 75. We have people 75 to 84, we have people 85 plus. So we could really tell the differences. We don't just say, look, 60 and above, they are all seniors or elderly. We don't see them all in one basket. So that's really the number of, the percentage there. When we move on to sub-cases, you find it's a much more higher percentage, 72.5. Then, of course, non-cases among all the participants, 76.1, right? Gender, we find that, yep, no surprise there, women more than men. This is a phenomenon even for just depression in general. Younger people as well, middle age as well. Okay, this table shows socio-demographic characteristics. So we move on from the table just now, and part two of the last table. Oops, sorry. We find that the cases belong to the widowed, married, cohabiting. Same thing for the sub-cases, same thing for the non-cases. That's a big proportion. When it comes to education, the cases, well, seem to belong to the not so high, completed primary. And sub-cases, you have completed secondary, as well as completed primary and below. And the non-cases tend to be a little bit higher. You have none of those. You have only 14.6%. 14.6% of the non-cases having no education at all, or reporting no education, self-report. Right. So those are the ones. Okay, at the bottom here, did the doctor diagnose the person, or the person just self-diagnosed? So most of the time it's a no, which is not a good sign, right? Right. So when you have an illness, it's better to be diagnosed because you can be given proper treatment. Somebody knows about it, right? So if you buy that idea, then no here for cases 94, almost everybody. Here 98, here 98. Okay, no cases, fair enough. They're no problem. But for sub-cases and for cases, we find that they haven't been diagnosed. It's only at this point, that means at the point of joining the study, when they were doing the HCAT, which is really the measurement tool, that they were discovered by the researchers to either be sub-case, subsyndromal depression, or a real case, a diagnosable case. Of course, then the researchers would do the ethical, right, which is to report, to advise the person to seek help accordingly and provide the resources accordingly. All right. Okay. So I've said this already. This depression or mood disorder is increasingly a public health concern. The textbook uses significant to refer to US situation, right? And one of the reasons why is, as I have said earlier, there are adverse outcomes across a broad spectrum of life, not just when it comes to mood. There are adverse outcomes. Now, let's see who remembers the 7 symptoms, no, in fact, 8. 8 symptoms or checklist of depression. Who remembers? Okay, I gave an acronym, I think, on week 3 or week 2 that you could quickly use to check whether anybody, right, or if somebody asks you, or if somebody asks you for help, you easily check that. So let's see who remembers. So I've given one away. Given one away just now, right? Suicide is one symptom, right? So suicide. So which are the others? Sleep problem. Yep. Sleep. Okay. I think I should write here. I can reach it. Okay, so we have sleep. We have suicide. What else do we have? Sorry? Appetite. That's right. Appetite. Interest. More or less interest? Lower interest, right? In usual affairs. Yeah, exactly. Who said that? Energy. Exactly. More or less. Okay. Jing, you say energy, huh? No. Okay. Somebody say energy. Okay, but it's correct. I don't know who said it. Okay. Energy is correct. Okay. So less energy. Okay. Somebody else? I heard something else. Mood. What do you mean? Because this is already a mood disorder. Like low mood. Feeling sad. Okay. Yep. Depression is feeling sad. Good. Yep. Okay, good. Others? Other symptoms you could check. So concentration, yes, very good. Right. Concentration. Any others? So we have 1, 2, 3, 4, 5, 6, 7. We at least have one more. Guilt. Yes, excellent. Guilt. 1, 2, 3, 4, 5, 6, 7, 8. Okay, did we? Anybody else? I think I can give you a clue. We're short on one. There's one more here. Memory. It's a yes or no. It's a either or, may or may not. I can write it down. It's a may or may not. Memory. So in older adults, in late life, often a person who undergoes depression or subsyndromal depression also have dementia. Unfortunately, very unfortunately. This is one of the reasons why clinicians find it very challenging to treat, because when you treat the first D, you have to treat the second D. If you treat the second D without treating the first D might become worse, right? And vice versa. Yes, anyone? Yes. Okay. So we have, I have the acronym I gave was the S for sleep, I for interest, G for guilt, we have gotten it so far. Then we have an E there for energy, C for concentration, A for appetite. Then what's the next one? P for what? Okay, it's called psychomotor retardation, slowness in movement. Extreme catatonia, that means you freeze there. You heard of that term? Catatonic behavior, abnormal psychology? Extreme, that's extreme. So S for suicide. So memory, probably a comorbid condition, comorbid with all these, right? Whereas mood, well, when you say mood, it's actually this condition. So of course, anyone who has subsyndromal or diagnosable depression will feel sad or feel low mood, but he or she may or may not have all these symptoms. He or she may have one or more. So if the person has 1 or 2, then chances are subsyndromal, unless those 1 or 2 is very severe and for very long duration of time, right? So if you have 3 or more, then okay, going into diagnosable range. Okay, questions? So this is just a quick checklist for us to remember. Okay, back to the, what is this? Epidemiology. So these are socio-demographic correlates. So you can say risk factors, socio-demographic risk factors of depression and sub-depression or sub-cases. What do we have? We have age, right? So how do we read this table? Look at p-value. If p-value is smaller than 0.05 means statistically significant, right? Then only you read across to look at the OR, or what we call odds ratio. If the odds ratio is 1.0, that means no difference. The chances are actually not statistically significant. It cannot be 1.0. So if it's bigger than 1, means higher likelihood or higher odds. Lower than 1, that means 0.5, 0.3, it means lower odds. But odds, of course, you must compare to something, right? So there's always a reference group. So you could see that, look, in this case, people 75 to 84 were more likely than, the reference group is 60 to 74, more likely to be diagnosed with depression. How much more likely? The odds ratio also tells us it's 2.1 times more, higher odds. So that's how we read the table. Okay. So that's really one risk factor, age. But interestingly, this 85 plus don't have. Nothing shows up. I wonder if the U band makes sense here. Remember the U band we talked about? You get happier when you become older. All right. Ethnicity. Compared to the Chinese, Indians and Malays had higher odds of being diagnosed. They also have higher odds of experiencing subsyndromal, that means one or more symptoms. Okay. What else? Marital status. When compared to the married, the divorced/separated, higher odds. You can imagine, you can kind of imagine some of the reasons why. Education, no education or none, compared to completed tertiary education, higher odds, 2.5 times or 2.5 times higher odds. Right? So these are the risk factors in Singapore. I ask you to, I mean, now you can start to think about, does that make sense with what you observe, right, around you, right? Is this a statistical anomaly, or does it really reflect late life mood issues in Singapore? Doctor diagnose, the risk factor is those who are diagnosed were, when compared to those who are not diagnosed by a doctor, those who are diagnosed had a higher, what do you call it, odds of having depression. Now, that to me, it's I would say a phenomenon. It's a statistical, or you can say it's a clinical phenomenon outside of the nature of risk factors, simply because doctors tend to diagnose. Doctors are there to diagnose, right? Psychiatrists are sitting in the hospital, sitting in clinic, right? Basically, their job is to diagnose, right? So no surprise there to me, this one. Okay. All right, we move on. Okay, I want to give us some time. You have this chart in front of you. In your groups, circle out those significant factors and also the odds ratio for subcases and cases. This will tell you which are the risk factors. So go ahead, I'll give you maybe a couple of minutes to do that in your groups, and then we can get each group to say out one or two. Okay, are we all done? Okay, looking at the list, I think we are done. Huh? Who needs more time? I think you have more or less done, right? Okay, looking at the list, is there any illness here you don't know what it is? TIA, what is TIA? Heart attack, possibly, it can possibly result in heart attack. Who knows what it stands for? Yes, I heard the word tran. Tran what? Not trans, no. Transient, that's right. That's T. That's right, ischemic attack. Right, got it. It's a mini stroke. So a normal stroke, essentially it's an aberration of blood. Okay? A mini stroke that happens such a split nano, I don't know how many fraction of a second, the person hasn't actually detected the happening. So you can say the effect of a TIA usually isn't immediately obvious to the person, whereas the effect of a stroke is almost always quite immediately obvious, unless the person passes out unconscious. Right? Then it's immediately obvious to the people around him or her. So I can be standing here talking. After 3 hours of lecture, I can go home without knowing that actually TIA has happened to me. That's what it is. That's how insidious it is, right? Or scary, right? You can say, right? However, I will start to feel the symptoms, right? Soon after. Numbness on certain areas of my body, speech problems, slurring of speech, let's say, if it happens to that part of the brain, and so on. Okay, so what factors? Okay, maybe we just go around from this side. Name one of the significant risk factors on that list. Okay, for cases first, for cases. Sorry? Okay, I didn't hear you. Louder, please. Heart trouble. Okay, yep. Okay, okay, this table in front. Cases. Diabetes, for cases. Yep, diabetes. And then this table here, 5 of you. One risk factor in that list for cases. Eyesight problems. Do you say eyesight problems? This one? Yes, for sub cases, but not for cases. So look at the p-value. Yeah, this table with Lukman and Crystal. Yep. For cases. Arthritis. Arthritis. Oh, where's arthritis? Okay, looks like I really have an eyesight problem. Okay, here, yep, for both cases and sub cases. Okay, all right, thank you. Okay, which is, okay, I won't insult intelligence anymore. Which is, to you, right, the strongest risk factor among those illnesses there? Look at the list again. Which to you is the strongest, or which two to you are the strongest risk factors? You said paralysis. Any other answers? TIA? Who said TIA? Yeah, TIA. Okay. Any other answers? Okay. Care to say why? Why paralysis and TIA? Okay. Right here. So you looked at the p-value. They are very low. Okay, thank you. So same thing for the TIA, right? TIA 0.012 for sub cases, p-value smaller than 0.001. Okay, how about the odds ratio? So let's look at the paralysis odds ratio. What do we have? 3.2 times as compared to, okay, who is the, or what is the comparison group? Is it stated here? That's right, there should be a comparison group. Okay, it's not written here. All right, okay. Paralysis, well, if you look at odds ratio, where is it? 3.2, right? Here for cases, 2.7. TIA, 3.1. Wow, that's humongous, 8.5. So you're absolutely right. So that's what we have. That's what I have. In fact, those are the risk factors, which is not too different from the US risk factors when it comes to illnesses. So when you read the textbook, you essentially see, I would say, 80% overlap with these. This is Singapore that I'm showing on the screen right now. Right? So usually, but not always, a smaller p-value tends to come with a high odds ratio, but not all the time, because you know there's an error involved, right, statistically. Okay, move on. Okay, we come to this hypothesis called the VDD, or vascular depression dementia. Right, the idea is vascular disease, such as stroke and all those things there, aneurysms, vascular malformations, and so on, they actually tend to make a person more likely to develop some depressive symptoms. Okay, so the word predisposes means kind of set you up for something later, set you up for depression later. Precipitate means trigger, like you have something now, the next moment you have depression. Perpetuates means makes it worse, aggravates. So in each of these three types of what we call worsening, we see that vascular disease has been found, okay, to be related. Why syndromes rather than symptom? Because as you know, symptom could be one or more on that list, 6 ECAPs on the right side. Okay, when you have several, right, and when they kind of follow a certain sequence, that means you develop, say, sleep problem first. Sorry, maybe guilt and low energy first before your sleep is affected. Or maybe if you develop sleep first, then something else comes. Right? Then that becomes a syndrome. Okay, so essentially 2 or more. So subsyndromal depression may not be diagnosable depression, right? So that's more than one symptom, but not enough or not severe enough or not high in number enough to be diagnosed, right, as MDD. So that's essentially the hypothesis. Why is it a hypothesis, not a fact? That's because it's very difficult to find direct evidence, okay, of predisposing or precipitation or perpetuation. Direct evidence. Right? In medical terms, we want to find, if we can find direct evidence, what we call dose response effect. Have you heard of this term? I think I should write it down. Write it down here. A dose-response effect. That means not a dose of medication or pharmacological treatment, but dose of, say, any of those risk factors. Could even be stress, perceived stress, subjectively perceived stress. Just a dose of it, and how much is one dose? Once again, is it's subject to argument. But once you have this whatever thing, whatever risk factor, then almost quite soon after you have the effect of depression, any of those symptoms. But when you don't have the dose, i.e. the risk factor, then you don't have the symptom. So that's what we call dose response effect. When the risk factor is there, it's followed by the illness or illness symptom. When the dose of risk factor is not there, there is no illness or illness symptoms. It is quite difficult to find this for many reasons. One of the reasons, comorbidity. Is this an effect of dementia or depression? Right, so that is the idea there, the vascular depression hypothesis. Now, how does dementia come in? We know, right? We know that dementia, there are already 2 types. One, we have covered the Alzheimer's disease, amyloid deposition, right? Amyloid beta and tau, right? Remember that? We now start to see association also between dementia and vascular disease. So mini strokes like TIA and normal and mainstream strokes may tend to predispose or perpetuate or precipitate somebody in terms of cognitive impairment. And it may go further than that. If you recall, there is this preclinical AD model that we discussed earlier. Right? After MCI, mild cognitive impairment, then that is dementia. Right? We know that dementia is more than just memory problems. Okay, so we see now this thing: vascular disease related to depression, vascular disease related to dementia. So could really the link between depression and dementia be vascular disease? So that is now a hypothesis that remains to be tested, to be investigated. But there's some evidence that supports, not incredibly strong yet. Hopefully, when you graduate, you go on to contribute to some of these knowledge, right? As a researcher, as a clinician, right? As an expert. Okay. Direction of association is debatable because we find association, so correlational study, which is cause, which is effect, we don't know. Right? Oftentimes, it's just unethical or impossible to manipulate, right? Experimental setup, you must manipulate But how do you manipulate disease? You shouldn't. Even if you can, right? You shouldn't. It's unethical to do so. It's immoral to do so. Okay. So this chart here shows this. The idea that there are two thresholds to be crossed. The first threshold, this vertical line, the second threshold. Okay, what threshold? We know that depression, right, it's biologically correlated or related to cognitive and affective circuits in the human brain. Okay, we know that. So when these circuits are affected, are influenced, right, we say a person starts to experience depression symptoms. Now, what we also see is that there are various etiological or various causes. Okay, where the frontal limbic system is concerned, we find that there is research often shows this, that changes to the frontal limbic system, the different parts of it, i.e. vascular disease, presence or absence, differing severity, right, may not automatically or may not very quickly entail depression or depressive symptoms. Why is that? Now, if we subscribe to the vascular depression dementia hypothesis, then what these researchers posit is that we need to cross a much higher threshold of this vascular disease, i.e. the vascular illness needs to be of a certain level of severity, intensity, perhaps even duration, such that the frontal limbic system, right, enters a situation called dysfunction. Then only we could see in this part of it the dose response effect, i.e. when the vascular lesion occurs, when a vascular compromise occurs, then the depression symptom is experienced. When the vascular, when vascular challenge or dysfunction doesn't occur, then there doesn't seem to have any perceivable or perceptible effect on the cognitive/affective circuitry that is usually associated with depression. So we are saying there are two thresholds here according to the hypothesis. So for sub cases, often perhaps first threshold is crossed, so we may or may not experience, may or may not be able to for the person to self-report all the various symptoms, diagnosable to a diagnosable extent. But when those are severe enough, right, second threshold is crossed, then according to the hypothesis, a dose response effect can possibly be measured. So this remains to be tested. So it remains you can say a theory. There's some support for this at the moment, research evidence. Right. Okay. So I think I've covered this. Vascular disease contributes to the clinical manifestation of dementia symptoms. I've covered that. Right, amyloid-associated depression. So, right, it's something that is being investigated right now. Defines a subtype of depression representing a prodromal manifestation of AD, Alzheimer's disease, given its strong association with memory impairment. Right, the APOE or APOE4 allele. We talk about this in lecture 3, right? And the amyloid beta or A beta over there are two main, you can say, risk factors. They increase risk for depression. They also increase risk for dementia, right? These two. So often clinician finds a challenge to distinguish between symptoms of depression and symptoms of dementia. Cannot distinguish between depression or depressive symptoms are a prodromal phase of dementia. Prodromal phase means kind of the earlier phase. Yeah. Okay. We go on to the psychosocial risk factors for late life depression. WHO DAS 2.0. What is this one here. Let me see what I have. The mental disability status. That's what it is. So the WHODAS 2.0 is really a measure of mean, sorry, not mental, a mean or average disability status. Disability, in other words. This is significantly higher among those with depression, in these cases, as well as subsyndromal depression, i.e. subcases. Right? You can see the mean is much higher than this. 8.7 non-cases, we have 18.7, 31.3, that's much higher than 8.7. Right? Satisfaction with life, fair and good, 95.6, here 85.1. So that tells us that as compared to older people who perceive life satisfaction to be poor, those who perceive life satisfaction or life to be fair and good, right, are at there is a higher mean depression score, which is counterintuitive, right? Is it counterintuitive to you? To me, it is. I don't like my life. Things are not going well for me. Things are not going as I expected or as I planned or as I would like. If I have these thoughts, then I'll be, well, chances are I should feel more sadder, feel more depressed, right? Turns out that it's the other way around. Well, it's not that there aren't such people who are in subcases. We are saying that comparatively, in comparison, right, the mean, the mean GMS HCAP, which is really the depression score, is higher for those who say fair and good. What does that tell us? Anyone wants to venture a guess? You use the word goal orientation, is it? Okay, presence or should I say ability or inability to form goals in one's life. Those whose life could form a goal because, well, they're yet to be established or achieve goals, then they fall into this category. SAS, what is SAS? Oh, okay, social economics, that is. Okay. Possibly. We don't really know the answer to the question I asked, but that's possibly one. Yeah, possibly. But of course, it might also work the other way around, right? Right? It might also work the other way around. So it is an empirical question. It's a question that awaits investigation by research. Okay, we should move on. Relationship between depression, functioning, quality of life, Well, we don't really see any strong, what do you call that? Let me see. But here we see, well, okay, here, feeling lonely, depressed by current loneliness, yes. So these are essentially the symptoms already. Loneliness, under loneliness, people who report various types of loneliness, right, will essentially tend to be more depressed than those who don't. So that is expected, right? You can see here. Right, we move on. These are social support factors. So which are the, okay, here. Chat or do something with one of your friends. Daily, 2 to 3 times a week, or at least weekly. Right? In comparison to those who never chat or do anything with his or her friends, 2 to 3 times a week, never, right? The answer is never. I mean, the question, never. You find that this odds ratio now is smaller than 1. It's less likely to be depressed compared to. Now, this makes sense. This is intuitive, right? Okay, let's move on. What's the other one here? Satisfied, right? Here, 0.5. Yeah, that makes sense. So if you feel satisfied with support and help from close friends, you're less likely to feel depressed. Makes sense. And has ever felt suicidal or wish to be dead? 20.2 for yes. So yep, that makes sense. So this is a strong risk factor. Very strong, 20.2, 20 times more than the other group to be either diagnosed, to be subsyndromal. For diagnosable, oh, it's higher, it's 88 times. 88 times. Okay. Which is why today it's quite clear when we read of or encounter suicidal thoughts among older adults, we always check for depression symptoms in the clinics. Okay, we are now at the last part of the lecture and discussion. Any questions so far on the risk factors? I've essentially shown you the three main categories of risk factors as they pertain in Singapore for late life depression. The textbook, well, essentially discusses these things as well, but for the US population, okay, you would find, I found 70% similarity. Right? Any questions, any clarifications or something that that interests you? Yes. Right. Which slide here? Is it this? Where is it? Is it one of these? Okay. Yeah, this one. This one. That's right. So the US one, good point. The textbook doesn't have a point on this. Yeah, that's right. So satisfaction with life isn't identified by the textbook authors or the chapter authors, to be specific, right, to be a risk factor. At least not in those times. It was written in 2014, 2015, US, not in those times. Yeah, good point. US and Singapore? For this point, you cannot. In fact, I should also add that the measurement tool is different. So here we measure by GMSH-CAT. So they use other things. They use BDI, back depression inventory. They use, I think, a total of 4 others. BDI is usually one of them. And then there is this CESD, Center for Epidemiological Studies, -D. D is depression. Right. And I think 2 more. Yeah. Okay, any other points, clarifications? So to me, this is really something that stands out, quite counterintuitive. Yeah. I cannot explain it. If you're interested, okay, you know who the authors are. The paper usually have an email address. That's when people write in to ask, are you sure your data is correct? For example, are you sure you didn't do anything wrong when it comes to analysis of the statistics? That's why we have every single journal article comes with a corresponding author among the authors. If it's a sole author, then that person is the corresponding author. Then the email address is usually provided, or at least what we call the workplace affiliation. That means so and so university, so and so division or department. Then you can find that person and ask. And because scholarly work is transparent, you can even ask for the data and analyze it yourself. And ask for the data, ask for what analysis he or she did, and then try to replicate the analysis. And if you cannot find replication, then that's when you start to ask. You can start to ask yourself why, and ask the author whether he, conducted the analysis correctly or not, or whether you conducted the analysis correctly or not. Okay. Okay. Before I go into the treatment part, which I believe will be interesting to most of us, how many of you actually went through in abnormal psychology or clinical psychology, any of those psychosocial or psychological therapies? In terms of doing it. Okay, in terms of watching it being done. So in class, in tutorial, did the lecturer, did the prof sit you down and then make people either do role play with a script or get somebody to sit in front and then say, look, let's role play and you tell me your story and then I try to whatever. Has anybody done this? You have? Which class is that? Child psychopathology, thank you. Who else you have? Okay. What class is that? Clinical in child. Okay, thank you. Anybody else you have? Okay, what class? Clinical psychology, yeah? Okay. So these three, any others? So these three of you, was it a demonstration? Was it a role play? Was it role play? Everybody does it, right? That means for child psychopathology, for clinical side, role play. Role play, yeah? Okay. Okay, all right, all right. Were you given a script? That means were you actually kind of given a chance to do it, administer the so-called psychological therapy? Were you? So you are. Oh, okay, I see. So you're actors and actresses. Some of you are cast for some disorder, and then some is cast for, say, clinician. Okay, I see what you mean. Okay, so you have to write your own script and act the script. Right, I see. Wow, script. That's interesting. Do you have to hand up the script? Submit the script to the prof? Right. No need to actually a written copy of the script. No need, huh? How about a child psychopathology? Thank you. Do you do role play, demonstration, or like him, video? Try to be depressed, you mean? What do you mean try? I see. I see. So everyone has a chance to act as a client, and everyone has a chance to act as therapist, and then you kind of swap roles. Okay. Okay. So that is role play, right? That's to me role play. Okay. Fair enough. I mean, demonstration would be a pair or two or three or one student with the lecturer, right, sits in front of everybody else and acts whatever role he or she is given. Sorry. Clinical have. Also, you also took clinical. Same as him. Okay. Same experience? Uh-huh. I see. I see. Okay. I see. I see. Okay. Excellent. Excellent. In that case, I just wonder whether this is something I want to do as a demo or as a role play, or I just talk it through. Um, okay. You would not be unfamiliar that the first line of intervention is usually pharmacological, right, for mood disorders and even for anxiety disorders and several other disorders. And for depression, we are talking about SSRIs, or selective serotonin reuptake inhibitors. SSRI is a term that you would probably learn already in, right, clinical or right, clinical psychology or abnormal psychology. Is one of those classes of antidepressants. There are other antidepressant classes. The second line, right, would be psychological therapy. Now, I got a question. I don't know whether these people who have taken those courses will find it easy to answer or not. But my question is this: why is therapy the second and not the first line? Actually, anybody. But if you have taken clinical, maybe you have thought about it before. Yeah. Need them to be willing to enter. Right. So therapy cannot help somebody get out of it, but pharmaceuticals can. Right? That's essentially what you're saying. Thank you. All right, got it. Others? My question is, yes, Rachel. Right. I think I heard 2 points from you. One is pharmaceuticals faster, quicker effects is right, dose response effect. You said a second point, which is last longer. What lasts longer? Oh, okay. Therapy lasts longer than The effect of therapy lasts longer than, thank you. Right? That's, in fact, what you just said is a very mainstream um, clinical thought. Essentially, that's what clinicians are trained in clinical school, are trained in graduate schools. I was trained that way too by my own profs in clinical school. What you said is something very practical, right? Yeah, if I can't come to your clinic, then how can you help me in any other way, right? But well, there are also other practical thoughts I could have. For instance, um, I could, if I want to come to a clinic, I don't need a medication. I can just come, right? Okay. Anyone with any other thoughts to that question? Yes.
Generally require more effort. Then you need to form that relationship. That is longer duration. That is therapy is more about managing your condition as part of the time. But antidepressant is more like what she said. It's to kind of like if you have symptoms of it, you can kind of tone it down straight away.
That's right. Yep. Therapy is more management, so longer time, right? Symptom management, possibly for first start, antidepressants and other medication. Yes, exactly. Those are very mainstream clinical thinking. Yeah, you want to say something, Jingyu? You're looking at me quite intently. I thought you wanted to contribute or contradict something I said. That's fine. And earn money. You as a doctor will earn more. Yeah. Okay. Thank you. Yes. Absolutely. I actually wanted to say that. I'm glad you said it rather than I say it first. That yeah, that many, right? Not most, I wouldn't say, but certainly the numbers have reduced. But yeah, even today, many of us still hope for a quick fix. If I can take medicine and quickly recover, then I don't have to go for therapy, right? But people usually don't think the other way around. If I can go for quick therapy and quickly recover, then I don't have to take medication. How many people you think that? It's not a happy thought to think that, actually, to have to think that. But if you have to think that, which would you think, right? Which thought will you believe, right? I mean, I don't know about you. You're entitled to your own thought, but yeah, chances are we find people who endorse or accept the first statement than the second. We somehow would say that is not entirely wrong or their fault, because for many of our everyday ailment, yes, medication does essentially help us quickly, right? Isn't it? When those things fail, then we start to think otherwise. We start to think of other methods. In the pandemic that happened last year, right? People really started to initially thought that it was cough, cold, fever, right? Self-medicate, right? I'm talking about people in Wuhan when it came where it came from. I mean, I'm not saying okay. Don't get me wrong. I'm not. All right. I have full of respect to those medical people there. Not condescending. I'm not saying it's a Wuhan virus or anything like that. I'm just saying, well, there is one place of origin. Okay, right. With all due respect. Yeah. So when that doesn't work, then people start to wear masks. When people start to see that the effects are quite drastic, people are dying from it, are experiencing very miserable conditions like breathlessness, then people start to pay attention to it, right? So we essentially see the same thing happening. Well, I would say that a pandemic like SARS, like MERS-CoV, and like what we're experiencing right now, yes, they begin as acute conditions, but treatment or management takes time. It is not a once-off or overnight or even over a week. But those conditions often start as acute, right? Something that you have to treat. So same thing with late life, except that often in late life depression or late life mood disorders, there are several acute things to be treated at the same time. Which should the clinician treat first? Which should the clinician pay attention to first? Right? Which antidepressant should be prescribed such that it doesn't what we call interact or clash or counter the effect of something else. For instance, right? Because the person may have comorbid physical or mental conditions, right? When it comes to psychological / behavioral therapies, um, um, if we where older people are concerned in late life, it's often that the person wants to gives a premium. I won't say gives a higher premium. Gives a premium to what we call a quality of life. Often it's called what we call health-related quality of life. Okay, if the antidepressant doesn't reduce the quality of life too much, older persons may essentially take it. Right? If going to therapy doesn't affect too much, then the person might take it. Right? So there are older people who kind of feel the adverse effects of antidepressants and start to perceive that is negatively or adversely influencing his quality of life. He's not feeling too satisfied. He's feeling lethargic all the time, let's say, and he associates that with the adverse effect or AE of the medication. Right? Then that's when he or she is unlikely to want to take it. And that is when, depending on which course he's in, whether he's already in the doctor's clinic, that means a case file has been recorded or not, he or she may or may not be amenable or available for therapy. Okay. Okay, CBT, you must have heard about it. Cognitive behavioral therapy. Right? Now, no prizes for guessing that actually this is one of those therapies that is found to be effective with older adults when it comes to depression. But the thing is that it is only in 2016, it's only in 2016 that this 6-module program, right, became the first comprehensive CBT-based mood disorder treatment program. So when I say comprehensive, I mean it doesn't just include those cognitive techniques and behavioral techniques, right? But essentially it's based on those. So we are talking about number 3 and number 4. Strictly speaking, it's only number 3 that is the behavioral part, and number 4 that is the cognitive part, the C and the B. The B and the C, respectively. Strictly speaking. The other components are built onto those to make those number 3 and number 4 more effective, more easily amenable, more easily, you can say, accepted or acceptable to the client / patient. Right, that's 2016. We know that CBT exists for I don't know how long. I think 60 years since the day of Aaron Beck cognitive therapy. Yes, we know that, right? But it's only in 2016 that a CBT-based program has been enacted and support is found in an RCT, randomized controlled trial, right, for this program. Okay. Okay. Those of you who have taken clinical, look at this. Have you learned this in your clinical child psychology? You have? Excellent. You can help me here to explain. You can help your group here actually. Let's see, how are we doing on time? 56. Okay. All right. Maybe we should do this. Now, let me just point out the active part of this cognitive technique / thought control exercise is really the fourth the fourth one here. The disputation or disputing of irrational belief or irrational thoughts, or what they call cognitive negative automatic thoughts or cognitive errors. There are so many terms for that. Okay, if you have taken clinical psychology or child pathology, you might have come across this one. So, probably I won't make you do the role play again, but just maybe as an example, this is describe a situation that upsets you. essentially allows the client to, well, just talk and vent and clinician to record the various elements of the situation, right? What we want to get, in order to do the fourth one, you have to get the second one, get those thoughts there. And often the thoughts will be, I don't know. Like, for example, let me give you an example. Say my father died and I feel sad. That's the situation. My father loves me, and he hopes that he could see me graduate from university, right? But before I graduated, he died. I cannot show him, my certificate, and he died suddenly, heart attack. We found him face pale and suddenly in his room doing the usual thing in the usual time. We could have expected that. No pre-existing illnesses. Right. So I've described a situation to you. My father died. State your thoughts in this situation. Often we will hear, I feel sad. So it's up to the clinician to uncover and understand those thoughts. Some people, initially, my peers and I in clinicals, we often like to say, what do you mean by sad? Then we realize that's not a very good way to answer or ask the question. What do you mean by sad? Well, I'm sad. Yeah? All right. So that's when training helps. When you, for instance, when you feel sad, you think about complete the sentence technique, right? So I feel sad when I look at his photo, when I look at his belongings. What do these thoughts mean to you? What do these thoughts say about you? Doesn't this sound like a reflection journal, reflective journal? Some of it, right? I feel sad. It says that I'm an unfilial son. It says that I could have done more to help him. I have done more with him, for instance, right? And so on. Okay. Consequences, we actually, after the feeling, and essentially that's sad. Person has verbalized it. There are, I would say, until today, 100 over ways to dispute that one could be trained, right, to dispute. Well, one way is written here, right? Other than the I'm a no unfilial son, what else could one in your situation could have thought? What else could somebody think in your situation? So a person could have thought that you have given your best, or you have been a good student, and so on. You were not responsible for his death. Right? That's just one way. Right? Asking for evidence is another way. Right? And given the assumptions of CBT, the hope or the assumption is that by suggesting or by uncovering alternative thinking, right, that the irrational belief of I'm an unfilial son would the strength of that will be reduced. Person will feel less hooked or less impacted by that thought, and a bit more impacted by healthier, desirable thoughts such as I did my best, right? And then the clinician could then check, what do you think now? I think I'm okay, or I think I could have done better, but I'm not perfect, something like that. Right? And then how do you feel now? Hopefully this is how you feel now. The intensity is different. You can ask scale of 1 to 10, how sad do you feel? So now you can ask the same thing here, right? So hopefully score is lower. So that is just a very quick run through. So yeah, so if we are doing a clinical class, we would have groups of 3, role play, observer, after that change roles, and then everyone will be either the client or the therapist or the observer who will take notes on both sides. Right, so that's what the essential part of this the cognitive essential, one of the essential parts of this CBT-based program. Okay. All right. Very quickly, we know that in late life there's a lot of underdiagnosis. Older people think they're okay. Older people think that going to doctor is worse than if I were just to live with the condition, live with the sadness. Okay, or may even think that depression is part of normal aging. Okay, so under diagnosis, under treatment, right? Or physicians may confuse due to dementia and other comorbid conditions, so misdiagnosed. Okay, and therefore the non-use of mental health is extremely high among the old. and the oldest old. Some of this has to do with, okay, those reasons there, low perceived need, moderate resources, cannot pay for it. Just only 2 days ago, somebody told me over LinkedIn that the UF healthcare could really be thought of as wealth care, where if you don't have money, you can't pay for it, you don't get the health you should get. Right? I don't know. I have never lived there, but that seems to be one increasingly strong mainstream view of the US healthcare system right now. Low motivation for mental health care, collaborative care. Okay, spend a little bit of time on this. The idea is this, that much as we can have CBT based program, if any program isn't collaborated with what we call discharge from hospital and home conditions and informal care, i.e. care from family/friends, right? The effectiveness is often limited. So right now we say that for late life depression management, the gold standard treatment isn't CBT. It isn't even CBT plus pharmaceuticals. It's not. CBT plus pharmaceuticals plus sunlight, these three things are essentially in the mainstream clinical literature the gold standard for treating depression, right? Those of you who have taken clinical psychology, you would know. Three things: sunlight or exercise or physical activity, any form of therapy, doesn't matter, and antidepressants. These three things, you add them together, gold standard for treating depression. For late life, no, that's not enough. You need collaborative care. That's the gold standard. So you need these three, yes, but you need a seamless, or you can say integrated care, where the person, when he moves from hospital to hospital, clinic to clinic, setting to setting, is being managed. Because depression in a late life could really, what we call, exhibit itself in various settings. You can say it can flare up anytime, anywhere. The other part about collaborative care is that all the various symptoms of other conditions, comorbid conditions like dementia, stroke, any of the vascular illnesses, hip fractures as well, and so on and so forth, should be managed in an integrated fashion. So we call that care coordination or coordinated care. Okay. Finally, the other part about collaborative care is that the home environment, i.e., the person who cares for that older person, older father or older mother at home, right, needs to be a part of this, you can say, healthcare system. Needs to understand what's going on, needs to know where to access information, right, needs to participate in making decisions jointly, right. Then that is what we call, you add all these together, then we have what we call collaborative care. It's meant to be seamless. So that is essentially the gold standard for late life depression, right? Yeah, quite a bit of work to be done. Okay, so some people have called collaborative care stacked care. That means uh, caring in increasing levels. We first care for your, say, this condition, then we care for your that. Then when we care for your second condition, we need to make sure that the first condition isn't neglected. So we sort of add on, so the next step. And then you add the third step, and then add the first step. Every step you add is an increase in the number of, say, setting, number of either professionals or informal caregivers, unpaid. Right? Every step you add is often, right, one new condition or one new issue to be dealt with. Okay. Yeah. And every step you add, well, if it's not managed well, can possibly lead to confusion and, you can say, treatment withdrawal or non-adherence, right, by the late life person, i.e. the older person. All right. Yeah. So this can apply to both subsyndromal as well as diagnosable MDD. Okay, this is one study which I will not go through. You can read. I will give you those slides. Right, then done in Singapore, only published recently, late last year, 2020, by the Associate Professor Ng Zipin and the team at NUHS. Right, essentially studying the implementation of CC, collaborative care, in Singapore for older people with depression, Singapore. Right. So this is, to me, a very exciting, what do you call that, step forward, right, when it comes to geriatric care. geriatric slash what do you call it? Psychological medicine. Okay, right. Um, just now, somebody asked about the various measures used in the US. These are the various measures: GDS, BDI, HDRS, MCS, which comes from SF12. Um, okay, I just now I talked about CESD, Center for Epidemiological Studies, having depression. That isn't there. That's another known inventory to measure depressive levels. Okay, so what should I? Maybe I can just point you to this one. The collaborative care group was 1.5 times more likely to show treatment response and remission of symptoms. More than 2 times to show right another treatment response on GDS and remission than the what we call using non-collaborated care or usual care, and NC means non-cases, means no depression. Yeah, as well as better quality of life, improvement, better care, etc. So that's the evidence. The authors concluded that there is strong support for effectiveness of CC for late life depression in primary care setting. That means GPs, polyclinics, and private doctors. And this adds to a small number of studies elsewhere in the world that suggest the applicability of CC. Right? Remains to be tested. Singapore is one of the earlier ones in the world after the initial, uh, uh, you know, the initial study in the that was published in 2016. Okay, if I'm not wrong, I think it's a German study. Right. That's it. Do we have anything else? Okay, these are quite straightforward. These are found in your textbook. Heterogeneity, subsyndromal, clinically significant, right? Two different things. To conclude means that either a person is full-blown depression or subsyndromal, right? Needs to be taken care of, and whether the person has other comorbid conditions. Second point, older adults are vulnerable to those two, onset and worsening. They're also vulnerable to higher risk for suicide and non-suicide related mortality. So physical illness mortality. Right. Risk factors, I've gone through those 3 main classes. Oh, there's also psychosocial, there's also socio-demographic in there. What research needs to focus on are these 3 things there. We know there are social demographic risk factors, right? Age, gender. But how do these risk factors interact? For instance, the older woman, we now know that the older women more than older men tend to right, have depression or have subsyndromal depression. But how about older women who feel lonely versus older men who feel lonely? Okay, how do these risk factors interact? Which one is more prone to depression, whether in terms of being triggered by something or perpetuated or predisposed? Resilience, right? There are individuals, older individuals who, despite many things, nevertheless do not show any symptoms. So we tend to call these people resilient to depression. But what is resilience then, right? How do we measure that, right? Do we have what we call factors for resilience? Could we then use these factors for resilience to improve the resilience of really, practically, like the older people? How do we deal with undertreatment? How do we deal with underutilization by older adults, right, of depression treatments? Something for us to do further research on. You can say deal with stigma. Yep, then that's when psychoeducation comes in, health education comes in. But probably it's not just those, right? Probably more than that. Perhaps we need to think about, say, better implementation of integrated care, so that the person don't feel so inconvenienced and so confused, changing from place to place, doctor to doctor, medication to medication, right? Perhaps we need to, if the person is not so educated, then right, deal with what we call lack of health literacy among the oldest old, who may be baby boomers, right? So we don't know. These are just my thoughts. Future research is required. Okay, I'm done. I'm done. Before the short break and the debate, any quick thoughts or questions on the subject? Over here, let's see. Online, we have some response. We have Stephen that says, I think GPs can be better equipped with knowledge and guidelines on pharmacological help for seniors. A lot of older people will balk at the idea of going to IMH. I have heard them call it Xiao King. Oh, okay, that's the Hokkien word. Place for the mad. I think GPs are allowed to prescribe antidepressants. Yes, that's a comment by Yue Ling to a certain extent. Certain types of antidepressants. Yes. Yes. Anything? Anything? No? Okay. If not, let's take a short break, 5 minutes, and then I'll hand over to the organizers for the debate. All right.
And concerning suicidal behavior, risk factors that serve as predictors are the onset of chronic illnesses that come with aging, the loss of independence, feeling loss of efficacy and satisfaction, environmental changes, cognitive changes, as well as behavioral and related changes, which all decrease the quality of life of older adults. So through this, we can already observe that the motivations for this behavior are quite complex, and they need to be confronted as an interaction of different factors and with an extensive multimodal health system. So here we can see a chart that shows you the rate of suicide within the general population. And from this, we can already see that there is a very large percentage that belongs to people over 70 years of age, which indicates that this is a very serious issue to confront. And before we start the debate, we would like to get a consensus on which side you are on currently before we move forward. So, yes, here's the QR code. Please scan it and vote. Just to remind everybody, the stance is late life suicidal behavior primarily reflects gaps in the public health system. I would like to remind everybody to please vote based on your logic, so not on your bias. So please pick your sides based on your own preconceptions and your knowledge of the topic. Just after you vote, you should see an option to put a question. Does everybody see that? See? Okay, yeah, yeah. Does everybody see it? Everybody see it? Okay, so everybody, this is how the audience participation will go down later. So you can later you can use this system to thank you. Later you can use this system to put in your questions, and this is an anonymous system, so we want to encourage once you reach 30 seconds before the time runs up, and then we will ring it 10 seconds before. So when your time has run up, we will thank you. Yeah. Yeah. So with all that said, if both teams are ready, I would like to wish both teams all the best and invite speakers from the proposition team to open the debate on late life suicidal behavior primarily reflects gaps in the public health system.
Suicidal behavior reflects the gaps in system as it is the root of the problem. Our third speaker, Amanda, will do all this further. Lastly, we also believe that viewing late life suicidal behavior as an indication of flaws in the public health system is the most practical and actionable. Viewing the risk factors in isolation does not lead to practical solutions, and thus, late life suicidal behavior primarily reflects gaps in public health systems and is most actionable, as our fourth speaker, Timmy, will elaborate on. We come to define late life as a person aged 65 and older who attempted suicide is considered as part of suicidal behaviors no matter successful or not. We also note that there is a higher lethality rate with late life suicidal behaviors, since not many are able to survive their first suicide attempt, as the organizing team has kindly discussed prior. We also structured our evidence around the Centers for Disease Control and Prevention (CDC's) definition of the public health system being all public, private, and voluntary entities that contribute to the delivery of essential public health services within a jurisdiction. To add on, the proposition also believes that public health systems efforts should entail campaigning efforts as well, and not simply medical aid focus. This is because we believe knowledge and awareness brought about by campaign efforts play a big part in healthy behaviors. The rest of my team will now proceed to further elaborate on the three main key points I mentioned above. Thank you.
So we understand where you're coming from, but we think that suicide in later life is complex and multifactorial. We believe that decisions on late life suicide reflect various factors and not only primarily gaps in public health systems. We'll be discussing how cognitive impairment, individual values, psychosocial support, and individual factors contribute to late life suicide. Research has shown that proximal determinants of health, such as mental disorders and physical illnesses, has more effects on suicidal behaviors than distal or even intermediate determinants that could be modified by societal interventions. Hence, the majority of suicidal behavior cannot be accounted for by gaps in public health systems. We argue that suicidal behavior instead clearly reflects other factors. Firstly, we believe that such behaviors reflect cognitive impairment or cognitive decline in older adults. Research suggests that deficit in cognitive inhibition performance underlies suicidal behavior among older adults, independent of depressive disorders. Being unable to inhibit intrusive suicidal ideations and restrain their thoughts and actions results in depressive rumination that eventually leads to the onset and maintenance of depression and future suicidal acts. Additionally, the inability to restrain and delete irrelevant information may impair older adults' capacity to respond adequately to stressful situations, leading to increased risk of suicidal behavior, especially during late life depression. Hence, later life suicidal behavior do not reflect gaps in public health systems, but rather the individual's cognitive impairments and deficits.
So a lot of research has been done to understand the risk factors of suicide among older adults, and we do acknowledge the importance of these factors contributing to suicide rate among older adults. However, it is important for all of us to understand that these risk factors can be mitigated by a good public health system. An effective public health system will act as a protective factor against these risk factors. Therefore, I strongly argue that the gap in the public health system is the most important factor contributing to suicide rates. For example, we all know that depression is highly associated with suicidal tendencies in older adults. However, one of the studies done in Norway found that even though depressive symptoms were present among some of the older adults committed suicide, only a few of them had been in touch with psychiatric healthcare services. In fact, the majority of them were not perceived as being depressed by those people around them or even the healthcare staff. This highlights that a better detection of depression and suicide risk among older adults could have prevented some of them from committing suicide. This study also highlighted the need for healthcare professionals to be better trained at detecting suicide risk in older adults. Many research has also found that regular screenings for depression and effective treatment for depression are the primary prevention strategies for suicide. Therefore, the inability to detect the depressive and suicidal symptoms highlight the gap in the public healthcare system, which has subsequently led to suicide among older adults. Research has also found that physical illnesses are highly associated with depression and they are one of the risk factors for suicide. Therefore, an effective public healthcare system that can adequately treat physical illnesses will be able to reduce depression and suicide risk. To add on to my point, suicide rates have been found to decline after suicide prevention programs were introduced. Specifically, suicide prevention programs that include depression screening, psychoeducation, and telephone support groups have all been evaluated to effectively reduce the suicide rates among older adults. Therefore, these highlight that effective interventions by the public healthcare system tend to reduce the suicide rates among older adults, supporting our stance that late life suicidal behaviors reflect the gap in the public healthcare system.
Late-life suicidal behavior can shed light on perceived social support for older people. Research has shown that the loss of social connectedness increases the risk of suicide and hence inducing suicidal behavior in elderly. This is especially so given that changing times have caused transitions in family settings. For example, industrialization of Asian cultures have transformed traditional family settings into that of a nuclear family setup, which can confine many elderly once supported by the extended family in a state of social isolation. Other factors such as the loss of family members, family discord, and living alone places older people in greater vulnerability of social isolation. Strong social support has a protective effect towards late life stressors, which may then reduce suicidal behavior tendencies. Family support is shown to be the main support that older people seek. A study has shown that some older people do refuse help from formal sources due to a preference for care from family members or friends. Similarly, some people also choose to be cared for by family or partners because they feel more at ease compared to being cared for by a stranger. This can be seen from research where prior to suicide, 45% of elderly contact with their primary care provider, while only 20% visit a mental health professional in the same period. This shows that elderly tend to seek those they are closer to and how the elderly view social connections as being more important than health services available. Personal preference to confide with someone closer than you over professionals is undoubtedly common across all ages, including older people, and it is a human need to receive support from someone important to us. Therefore, I stand by the viewpoint that late life suicidal behavior shed light onto social support perceived by elderly. Yeah, thank you.
Okay, so I'd like to restate that we believe that late-life suicidal behavior primarily reflects gaps in the public health system. So let's talk about culture, right? So we have our cultural ideas about mental health come from the first place, how we define and think about health. It's through global organizations like WHO who sets the standards and definition of health. So before 1948, health was just a mere absence of disease. But after 1948, WHO expanded this definition to include mental well-being as well, which sparked revolutionary change in how society approached mental health. Therefore, I believe that it is the way the public health system anchored and defined health for society that primarily shapes our cultural thought on mental health. So we can also argue that stigmatization could be a primary cause of late-life suicidal behavior, but what forms of stigmatization would we refer to? I think most of us, we know that we would think of cultural and personal stigmatization towards the mental illness itself. However, sociologists have described an alternative form of prejudice and discrimination, termed as structural stigmatization, which operates at the macro level and refers to specific policies of large entities, including the public health system, that place restrictions on the rights and or opportunities of persons living with mental illness, either intentionally or unintentionally. So cultural stigmas can only exist and be enacted within the context of social power, and propose that gaps within the system insinuate structural stigma, which is then evolved into cultural and personal stigma. For example, individuals avoid seeking treatment from I'm rich because they fear
each pays post-recovery clients and jobs with employers in their database, it makes employment firms aware of that these individuals have sought treatment for mental illness, lowering the quality of their employment opportunities. So this fear of having one's future or reputation jeopardized is created by structural gaps in the system, and such fears can be internalized by individuals, including older adults, who may feel threatened when using mental health services. Therefore, we believe that it's the gaps in the system that causes structural stigmas, which evolves to become cultural stigmas, deterring individuals from seeking mental health services.
Albert believes that late life suicide can be attributed to individual differences such as personal values, which can be also driven by culture. So, for example, Asian cultures where people value face heavily may not wish to seek help for mental disorder because it means anything to their weakness, or they dismiss the problem because they undermine the effects of depression. So this contributes to high societal risk as they do not seek help for their problems, which cause the disease to manifest into its later stages. Another example is in Japan, whereby suicide is considered culturally more acceptable, such that it is glorified in the face of disgrace. So elderly who perceive themselves to be useless through physical or mental disabilities may drive suicidal intentions as they do not wish to disgrace their family or themselves. Or cultures that values autonomy and believes that individuals have a choice in life, hence also allowing the option of euthanasia or assisted suicide. So, and it's found that elderly with more intense hospital care during their last years of life actually tend to seek assisted suicide when the option is available. So these are areas that good healthcare cannot prevent because elderly either see themselves or know that they are unable to recover from their illness and wish to seek a more comfortable way out. Lastly, those that value self-control to cope with adversity want to be in control of their lives such that they put them at higher risk of suicidal behaviors when faced with adverse situations. So these are such as men who value stoicism, control of emotions, and competitiveness. They feel useless, incapable, and powerless when they grow old and lose their positions as sole providers. So this was also used as a reason to explain elderly male suicide. And hence we believe that personal values actually affect late life suicide behaviors too.
While the points that the opposing group has brought up are all very valid, public health systems hold the most weight when it comes to implementing late-life suicidal behaviors, as risk of mental health issues and consequently suicide are a result of deep-seated systemic fault in society. While it is true that individual differences and risk factors can account for the occurrence of late-life suicidal behaviors, looking at the issue from a macro level, we realize that institutions and systems hold the most power in determining late-life mental health and suicidal behaviors. Treating late-life suicidal behaviors as a public health issue can help mitigate the issue most effectively, as it can level the playing field and allow greater accessibility to mental health care across all demographics at a societal level. This would mean all the previous hurdles to toxic behavior, like the high cost of treatment or stigma, would be eradicated. Take the case of the common flu. In the past, the flu was a deadly virus and many deaths resulted from the contraction of the flu. Similar to suicidal behaviors, certain demographics of people are more vulnerable, like older adults. However, over time, healthcare systems have evolved so that the majority of the population are more immune as better infrastructure has been built to manage the flu on public health level. This is through increased awareness and education of both physicians and patients, as well as the wide accessibility of flu vaccines and medicines. In the same vein, the current prevalence of suicidal behavior in older adults should be viewed at the societal level as a public health issue, as it is the most actionable. Simply attributing suicide to social demographic factors is rather myopic and potentially ineffective at tackling the problem on a larger scale. Thus, we propose that public healthcare systems should work on building a more robust mental health care system, especially for older adults. This can be done through reducing costs of treatment, insurance coverage for mental health, and allowing access to government subsidies like Medicare to be used for mental health care.
Okay, so I would like to bring everyone's attention to the diagnosis stress model. We believe that instead of projecting
Late-life suicidal behavior may in fact point to individuals' own personal factors early in life that predisposes them to suicidal ideation. According to the diathesis stress model, diathesis refers to factors that render individuals to be more vulnerable to suicidal ideation, such as one's personality or genetic makeup. For example, having a short allele for serotonin transporter gene is associated with greater risk for depression and associated suicidal behavior. Yeah. So the different tolerance for environmental factors doesn't reflect gaps in public health system, but rather the individual's own negative life experiences unaccounted by public health system. So upon hearing this, you may start to think that the issue lies with the public health system for not having healthcare policies to detect risk factors of suicide, such as compulsory screenings. And maybe you might think that if the public health system were really flawless, it would do something to detect these risk factors, right? But it is important to note that although research has been done to evaluate risk factors independently, what we mentioned, not much research has been done to identify how risk factors interact to affect the onset of anxiety and depression in late life, which we all know confers higher suicide risk. So the interaction is key here because mental disorders do not have a purely dispositional or purely environmental cause. They often entail an interaction of both. Therefore, it would be unfair to put the burden of responsibility on public health systems when the science and research hasn't even advanced to the level of understanding yet. The problem is not the healthcare system, but primarily the lack of science and research that the public health system then uses to create empirically based interventions. And I'm sure we all wouldn't expect the healthcare system to implement policies that are not backed by strong and scientific research, would we? Therefore, rather than public health system, suicidal behavior is a reflection of the lack of research. Thanks.
Now we'll be moving on to the audience participation and freestyle debate. So, we'll be starting with the first question, which is through competition. If it is a worldwide issue, how can the public health sector begin to take responsibility for suicidal behavior unless it is clearly across the board?
Can we ask for clarification?
Was the person who posed the question like to
Yeah, so like basing on the slide that you showed earlier, they show that like worldwide, right, suicide rates are high for elderly specifically. In fact, compared to other populations, elderly one is like much higher. So it is essentially a worldwide issue, and how it helps sectors differs among countries, right? And how can it so we the healthcare sector, the gaps in healthcare sector causing these issues. It seems to be a culturally diverse issue in which we
Thank you. I do agree that we cannot. I do want to like refocus us, like everyone, to the motion which is primarily reflex. It didn't say only reflex. It didn't say mostly reflex. Primarily, and then they have also kind of reasoned with the three different definitions of primarily. So I do agree that there are a lot of other factors that goes into trying to like help mitigate this problem. It's a whole worldwide, not just in Singapore. But if you think about it, like in terms of actionable, in terms of fundamental, in terms of how important the public healthcare system is, I think it's undeniable that it's a primary factor. It's not the only person responsible. It's not the only thing it's not the only factor, but simply because it's able to change versus other individual factors, simply because it has been proven that there is factors can actually help negate these risk factors, it should be the primary, like, it should primarily reflect the gaps of the healthcare system.
now we'll be moving on to the next question. For the opposition, can the public healthcare system be effective in also reducing the impact of cognitive impairment?
public healthcare system can be effective in reducing the impact of cognitive impairment, but despite so, it wouldn't mean that public healthcare system are what big like suicidal behavior reflects. So like we feel that it can be effective, but it doesn't change how we view the notion that that it isn't that late life suicidal behavior does not primarily reflect the gaps in public health systems.
So for the next session, for the proposition, would you say that suicidal behavior will be mostly eradicated when all the gaps in public health systems have been covered? While the proposition team is discussing, we would just like to remind the audience that we won't have much time to answer all the questions. So if you have any questions that you would really like to be answered, you can press the thumbs up in the Q&A.
Okay, we have an answer. So like what we believe is that because the current healthcare system across the world, maybe in Singapore, just in Singapore, is still quite inadequate when it comes to dealing with mental health. And we would say that when all the gaps have been covered and closed, that there will be an adequate support system for people facing suicidal thoughts or tendencies to seek the relevant help that they need. And thus it won't mostly eradicate, but it will definitely improve the current situation. Because there will be the right support systems in place to catch those people should they need help. Because currently, I would think that a lot of people have suicidal ideation or suicidal thoughts or behavior because they really don't have anywhere to go because of the stigma, because of everything. But the stigma also stems from the system. So when we change all this, it will solve the root cause of the problem.
Thank you for the question. Now, we will have the last question. Either proposition or position, either one of you can answer. What would you consider public health to encompass?
So actually, the last part of my argument is not even like defining everything was really on how we structure our argument for defining public health system. So we took the CDC definition that includes all public, private, and voluntary entities that contribute to the delivery of essential public health services within a jurisdiction. And for us, we also believe that the public health system encompasses campaigning efforts. So it's not just the medical aid that the system can offer, like your hospitals or like clinics and therapy places, but it's also campaigning efforts that help you build your beliefs and your ideation around mental health. Which is why we come to also believe that it's because of this that we view public health systems gaps as the primary factor over cultural and everything else. It's not that they don't matter, but more so that the public health system affect your cultural views and your stigma views about it than the other way around.
Proposition, would you like to add? If not, we'll move on to one last question. For proposition, how is the public healthcare system responsible for tackling structural stigma?
So actually, I already talked about structural stigma. So like WHO, they actually said that across worldwide, like yeah, they revealed that actually across countries, right, there's really a lack of insurance cover, which is the mental health parity. And also like the how like
training. And then just now the lecture we also talked about how it's very difficult to differentiate dementia and depression. So then when physicians, they don't properly diagnose and don't properly treat, all these things are because of what the system enforces and what authorities enforce in the first place. Yeah, so so I think that is why the public healthcare system maybe insinuates such structural stigma. And I think a lot of us don't really, we don't really, when we talk about stigmatization of mental illness, right, we always think about the cultural and personal stigmatization first. Yeah, but we don't really take into account how the public health system and how they play a huge part in structural stigma that actually insinuates and evolves into cultural stigma in society. So I think this is really just reinforcing and backing up the notion that we believe that life suicidal behaviors primarily affect gaps in public health system. Doesn't mean that the cultural and personal stigmas and the individual risk factors, social demographic risk factors are not important. We do believe it's important, but still it is primarily because of the structural stigma that the public health care system insinuates.
Just now you're speaking about the structural stigma, right? I feel like your direction is a little bit wrong because who is the one creating the stigma in the first place? It's not the structure, right? Like it originates from the societal level. That's why and the structure adopts it because people create structures based on cultural stuff. So I think society's stigma towards depression may aggregate negative feelings and give shame and to avoid judgment from other people because they have a psychological disorder. The elderly may keep the problem to themselves instead of seeking help. So it's important to clarify that even though they do seek help, they're reluctant to report psychological symptoms. Symptoms. So the culture that sees value in people who contribute would be less accepting towards the elderly because they don't really contribute that much to society. So yeah, this kind of cultural view may result in suicidal risk. And certain cultural influences may amplify or predispose individuals to midlife suicidal behavior. And research found that there exist certain cultural scripts that results in different motives that leads to midlife suicidal behavior. So, oh yeah, oh no, okay, wait, I'm not done.
Thank you so much for the question. I think this question is a good question because it's kind of like a chicken and egg thing. Did the egg come first or the chicken come first? But going back to the definition of primarily that you are trying to focus everyone on, well, that is actionable. Because having like an individual stigma, etc., is not as actionable as thinking of it from how it can be solved. For example, like individual stigma can be solved by the public health system through campaign efforts, through the fact that they can change the structure and hopefully that when the structural stigma is eradicated, it will trickle back to society. So I feel like it's more productive to think of it as a public health system problem rather than just a purely individual stigma problem. I do not disagree that it is a problem, but I do think that is, as I said, more productive.
Okay. But I feel like it's because of the cultural perception regarding mental health and not to get in the public health system though. Like, I don't think we should put the blame on the public health system when the culture as a whole, being as pervasive and global as it is influencing every aspect of society, including like the structure of the healthcare system. And therefore it's just like, yeah, if society is not ready to destigmatize mental illnesses, then yeah, how can you expect like the system which is based on the cultural values to do it? Yeah, thank you. And also, yeah, when you say actionable, actually, like I feel like although it might be actionable, is it really useful in the end? Like you know that like inherent like inherent mindsets gonna be changed over time. And if you say that like when we improve the public health systems, it might not actually even like it might help the situation, but it will not help the situation like fully. So in the end, it's not like the primary factor that influences late life suicidal behavior. Meanwhile, it's like the point our notion I feel like is more it's more of like the primary factors where it comes from like a personal level and as well as like the social level. Yeah, thank you.
Many studies have actually shown that suicide when such prevention programs were started, then suicide rates tend to decline. So and also another thing is if you think the public healthcare system is not the most important factor, right? Then how would you explain why rural areas tend to have a greater suicide rates than urban areas where public healthcare system is actually more accessible in urban areas and not in rural areas?
So one more point to add. Where do you think those implicit moral biases come from? It comes from the society that you're in.
So based on what my group members have discussed, we have seen how late life suicidal behaviors actually reflect not only the gaps in public health systems, but also relies heavily on other factors such as the cognitive impairment, values, individual needs, and social support. These factors influence the late life suicidal behaviors in individuals more directly than the possible loopholes of the public health system. Deficits in cognitive inhibition components has shown to underlie suicidal behavior among the elderly independent of any distressing disorders. The inability to inhibit intrusive suicide ideations and to suppress this irrelevant information could lead to depressive rumination and impairment of the elder's capacity to respond to life stresses respectively, and eventually leading up to increased depression and hence suicidal behavior. Next, we talk about how the perceived social support has more effects on suicidal behaviors. Older adults have shown to have a preference to seek those that they are closer to and refuse help from outsiders or people that are not close to. So higher suicide rates does not necessarily stem from the gaps and flaws of the public health system in aiding people with suicide ideation, but individuals not consulting these professionals instead due to a higher perceived support from the people around them. Following, we talk about how values influence suicidal behaviors in both age. Different views on suicide by individuals and society have been found to impact suicidal behavior. These views can vary from being abound to show control of one's life and death, or to save face and prevent a sense of shame rather than asking for help when they are psychologically distressed. There has been a growing acceptance towards suicide as seen for the practice of euthanasia or assisted suicide. Lastly, we talk about how personal factors in early life predispose late suicidal behaviors. Based on the disease stress model, intolerance to environmental triggers like negative life experiences unaccounted for by the public health system render these individuals more vulnerable to suicidal ideation and behavior. The lack of science and research, rather than the insufficient healthcare system or policies, play a larger role in late life suicidal behavior. And to end off our debate, we feel that the gaps in the public health system are just a small aspect of the social safety net in question when it comes to late life suicidal behavior. In fact, these gaps in public health system mostly just serve as a mediator rather than a primary factor of suicidal behavior. And therefore, from this discussion, we can see how late life suicidal behaviors are not primarily caused by the inadequacies of the public health system. Thank you.
Okay, right. Okay, thank you so much. By the way, I think that the word blame has been thrown around a lot in this debate. We're not blaming anyone, we're not blaming the public healthcare system. There's no blame here. We just want to improve the mental health system. And we see that the public health system is the most obvious way to help. It's not a blame game, it's not a blame game. And the public health system improving will help to reduce late life suicidal behavior, and the stats show it, as Sean and I said. Also, I feel like it's interesting that the opposition actually raised up a lot of evidence that can kind of skew it to our way as well. For example, 20%, we say 20% of the people actually visit a mental health professional versus like a GP. Isn't that a problem with the public health system? Why aren't they visiting a mental health Is it because it's not enough? Is it because they don't view it as personal as you have insinuated? And won't the good campaign effort done by the public health system help mitigate that? Isn't that a gap that the public health system can very obviously and tangibly counter? Also, you talk about community impairment, and as the audience participation said, isn't it part of the public health system to mitigate it as well? And you talk about the disgrace in society and possible stigma against mental health. Isn't it from the lack of awareness of mental health? Can a public health system awareness campaign help there? Furthermore, we talked a little bit about the fact that it might not help it at all. And the thing is that, the truth to be told, we have no idea either. The stats show that it will, that's why we trust that it will. The other way you can think about it is, if you think about it in the structural stigma sense, nothing will be done. There's thinking of risk factors by itself is not actionable. You can't do anything about it. But if you think about it from a system point of view and how it can be changed, how it can be mitigated, then can it be a possible solution to a problem that we are facing right now. And to summarize, we structure our argument according to different definitions of the word primarily. First of all, we define primarily as most important, and she elaborated on the argument that protective measures and policies implemented by the public health system can minimize the effects of many risk factors in late life suicidal behavior. Also, we also define primarily as fundamental. We believe that the public health system affects the cultural and social demographic factors that the opposition has touched upon. We do not disagree they exist, but we stand by our argument that the public health system has a role to play in affecting society and culture. Amanda then brought up structural stigma as the root to the problem. Lastly, our fourth speaker, Tini, actually argued based on the definition of primary being most actionable. We believe that viewing risk factors and problems associated with life suicidal behavior in isolation is not productive. Only when we look at it from the lens of the gaps in the public health system can we produce more actionable and practical solutions to the problem. Therefore, we believe that late life suicidal behavior reflects the gaps in the public health system. Thank you.
Thank you from the we now moving on to the interpersonal, which is about Dementia. After 10 years,
Okay, before the organizers come back to us with their observations and ask you to vote again, let me just make a quick comment first, and then hopefully that I don't steal their thunder. Both groups kind of talk about public health system, and I really like it. It's related obviously to what we've learned. I use the term collaborative care, seamless care, step care. Um, and then both sides talked about what do you call that? Whether essentially, to me, is whether or not public health, right, is one factor, or the public health is system is the or one of the reasons, right? So I'm sure organizers will talk more about that. I just want to introduce this new term called integrated care, right? It is a growing field. It has been around for the last only 10 to 15 years. It's called integrated care. And Singapore is just started to embark on integrated care. Well, some people might argue that Singapore has been trying to do it for a long time, but really there is a new division in the Ministry of Health called the MOH, Office for Transformation, that is trying to transform Singapore healthcare, that essentially tries to do integrated care. It's not a simple understanding of what integrated care is, because different people have different understanding of what it is conceptually to even begin with. So the implementation, you can understand, the translation into implementation will be different, right? There's different levels, system level, to organization level, right, to clinical level, and then varies by settings and different, of course, disease types is just one type of differentiation. Okay, I'll continue a bit later, but let me hand over to the organizers first. Okay.
in which we can see how structural stigmatization has the potential to impose on the rights of marginalized communities, and how this inequality in public health power structures can lead to lack of help-seeking behavior. With the proposition raising the example of lasting medical records affecting future employment through the employer stigma. Ultimately, the proposition makes the point that public health systems operate with the most power over late life suicidal behavior, as it ultimately provides the most accessibility to affecting the public healthcare system. On the other hand, opposition believes that mental disorders and physical illnesses have a bigger effect on suicide than societal interventions, and this cannot be accounted for by the gaps in public health systems. Instead, it reflects the individual's cognitive impairments and deficits. Deficits in cognitive inhibitions underlie suicidal behaviors, as individuals are unable to inhibit suicidal ideations, which leads to the onset of depression and future suicidal acts. Opposition also mentioned a point on social support and the loss of social connectedness due to changing times. Furthermore, opposition believes that individual differences and personal values are driven by culture, which undermine the prominence of depression, causing the disease to manifest into later stages. Lastly, opposition also mentioned the diagnosis stress model, in which the different tolerance levels for environmental factors reflect the individual's own negative experiences, and there is not much research done into how risk factors affect late life, and mental disorders do not have a single cause.
Right. So here are some points we have also considered. So for the proposition group, while you did mention solutions such as providing subsidies and lowering costs, you did not explicitly mention which group of seniors are currently falling through the gaps and will benefit from improving the public health system, such as people of lower SES, which hinders their accessibility to healthcare, which may act as a risk factor for suicidal behavior. I feel like this may have helped strengthen your point and also back up your proposed solution. Secondly, mood disorders in older adults are also quite uncommon. This is one point you could have mentioned. So as shown in today's lecture slides, the only 3.7% of the population and only 13.4% have subsumable depression. So as public healthcare systems cater to the general population, it is possible that such uncommon disorders are overlooked. Secondly, for the proposition team, we feel that the above points could have been brought up to strengthen the arguments. So the opposition could have focused a bit more on solutions and proposed how to go about tackling late-life suicidal behaviors outside of the public healthcare system, instead of discounting the solutions provided by the opposition solely on that. This could also help them. This could also help you convince us that tackling societal issues or personal issues or cultural issues will be more effective than filling in the gaps of the public health system. Secondly, you could also have let us know how you define public health care and how your definition shows that it is not primarily responsible for late-life suicidal behaviors. Yeah, so now we'll go on with the post-vote. Yeah. So, same thing as previously, just vote according to your personal opinion, not based on which group was more persuasive. So if you did change your opinion, just vote accordingly. Is everyone done? Has anyone not voted yet? Alright, congrats to the opposition.
Okay, thank you. Thank you. The voting in no way shows which side did better in the debate, but where you stand. And correct me if I'm wrong, it seems like it's not much change from the pre-vote, pre-debate. Was that right? About one third, two thirds, kind of. Oh, it swapped around. I see. Okay, all right. Um, okay. That tells us something. That we are open to have our opinion changed by facts, or at least the presentation of facts. Okay, some things that I thought were memorable. The proposition, I think in the form of Alastair, stress primarily. I think that is memorable to me. To them, to proposition, public healthcare is the most important in terms of possible cause, as well as what you say, actionable items or actionable strategies. Um, Opposition brings up quite a fair bit of, I think we'll have 3 or 4 main points which are fairly valid in my opinion regarding, and I think the organizers summed them up quite well regarding how we ought to look broader than the public health care system to understand suicidal behaviors in life, right? Which is great. By the way, you will share with me the slides, and then I will share it with the rest of the class. Um, let's see. Okay, I don't have anything to add from what is available in the textbook. You essentially, the main points are there already. That essentially, we talk about, the textbook talks about older person having some kind of risk profile. Talks about suicidal behavior, like suicide is highly associated with depression. I think both sides has alluded to that, and right, yeah. So I don't have anything in terms of that factual things to add. Okay, one thing for us to think about. To what extent is a public health system a product of what we call values? I think we somewhat, to me, we are somewhat at this juncture. You see, any system, right? So you can have social system, so you can have a transport system, right? You can have education system, right? We are in higher education. So where health is concerned or healthcare is concerned, we have public health, we have different acute health, we have primary care, and so on and so forth, right? To what extent, right, is a public health system, right? You can say an effect or an outcome of societies or societal values at that point. So the areas that public health focuses at any one time in history, in time, right? The type of population or the segment of population that it tries to look after first or second, in whatever priority that it decides to do so, right, may or may not, right, reflect the societal values or priorities at that point. Turn that around, um, um, society, when um, when giving, what do you call it? Society might be a product of, or yeah, a product of societal construct. Sorry, societal. Yeah, our societal values might be, right, an effect or a product of public health system too, right? Public health system could, well, devote resources to caring for certain groups of patients, to giving out certain education, health education or psychoeducation messages, right? And that might, right, change values, priorities of many human beings in that society, living in those places that system, that health system has influence over. So this will, well, which is a more effect of, which is cause, which is effect, that is essentially not something that even researchers are concerned about, because that the forces are always in flux. You can almost, if you take a step back, you can say it is uh, is subject to the governance and political system even, right? So we are not going to go so far beyond, you know, where we start off, where we started off. So however, in the context of this motion, right, one could, with reference to any specific public healthcare system, right, argue either side. So if you, depending on which you are familiar with or which you believe needs greater change, say for instance, you're familiar with the Singapore healthcare system, then you may refer to, say, a specific aspect, a specific component of the healthcare system, right, to argue either side. I think there was some attempt at this already, which I commend both sides on, regarding stigma. Both sides mentioned stigma, right? Proposition mentions structural stigma as an effect or as a design of the public healthcare system, right? The opposition talked about cultural stigma, social stigma, right? And the effect on the individual, in individuals' utilization of health services, individuals, you can say even cognitive processes in accessing health service, right, in late life. So that's okay. There are specific aspects of our health systems that kind of will lend credence to either side. But it is clear right now that Singapore is spending quite a bit of resources. Giving, if you think about the various sectors in Singapore, healthcare is one of the sectors that is getting more resources, getting more slices of the budget, of public monies. Okay, and I won't say social care is getting more. In fact, elder care or aged care is more a responsibility now of our Ministry of Health than of Ministry of Social and Family in Singapore, more so than last time, than ever. In fact, we want to think about why that is so. Why do we want to give more resources, give more responsibility, therefore, to healthcare to manage an aspect of life which is aging, right? That actually span various facets beyond health, or at least beyond what we think to be health. So proposition keep referring to WHO's concept of health, and rightly so, right? To say that it is a changing, concept. And so today, what kind of concept do we have with regards? What kind of concept of health does the Singapore, say, healthcare system hold, in your opinion, based on what you have observed, based on, say, even the prevalence and the prevalence rates of late life depression that I presented just now? Right? What aspect of the what aspect of health, what concept of health do we have there that says this? I like the opposition's drawing in of bringing in of the what is that theory, diathesis stress model. Is that right? Um, that is one of those facets of the medical model, which is awesome. That explains certain phenomena and which unfortunately does not explain other phenomena. Right. So you used it to your advantage. You used it to help us understand the opposition side, which is awesome. So I don't have anything to add really. In my mind, this is a motion that, yeah, it's almost like the nature-nurture debate. The strength of it on each side really depends on the empirical evidence available. Yeah, and evaluation evidence. Okay, so I will conclude there, and that's really it for today. Um, I hope today's discussion on depression and suicidal behaviors in life has shed light on a topic that might be not so much discussed even among older adults, you know. And I hope none of us feel discomfort or too much discomfort enough to be in distress. If you do, feel free to come and talk to me. Approach me in various ways, whether in person or electronically. Okay, if nothing else, thank you very much. Next week we have our final debate, and that's it. And then we have one more week, I think. 2 more weeks, that's it. Thank you.